Hi everyone and very warm welcome to all of you. This session is specially designed for you for discussing the CMS paper that actually was had the last Sunday we had. You might have appeared for this exam, the Combined Medical Services for the UPSC. And the reason for discussing this paper is that a lot of clinical questions needs to be integrated. And the good thing about the paper is if you have a very solid base of paraclinical subjects and preclinical subjects, the number of questions you would be able to easily solve in this paper would be not less than 80 out of 240. There's two papers may at least that. So what I can tell you for one fact is if you have done my classes from pathology, I will be discussing today around 46 plus questions, and I can proudly say all of them are from your notes only, not the paper as such, but from your written notes in your usual day-to-day classes only. So the basic idea of doing this for the NEET PGS, these questions might be repeated there because a lot of questions are quite similar there. And secondly, it gives us a new pattern of solving a question because a lot of them have like a question option A, option A, B, A, B, and C, 1, 2, 3, 1, 2, 4, and we are not really very used to looking at those type of options because those are really asked only in INICET. So the take home point from this session that I'm doing right now is to, first of all, when you put a question to you, try to put the answer as soon as possible and try to understand my very crisp notes and discussion. I'll doing that. I'll not be stretching it quite long so that we can save some time also. But I can assure you that this will be a very fruitful session for you, especially if you're preparing for the NEET PG or the coming NICT in the November 23. So those who have joined me live, first of all, I guess a warm welcome to all of you, those who have joined me. So I'll start the session without any further delay. But one thing for sure, we are going to discuss at least 46 plus questions in the UPSC paper 1 and 2 combined, and that makes 1/6 of the entire paper that you can get from this particular session completely. So guys, without any further ado, let's start this discussion. So as soon as you see the question, I want all of you to put your answers here. I'll discuss it one by one. The following are recommended for the management of tumor lysis syndrome actually. So first of all, let's understand what is your answer here. What is tumor lysis syndrome? A tumor lysis syndrome, first of all, you should understand, it is a case where any tumor cell, when you induce a chemotherapy, it will show lysis, right? So what comes out from the lyse tumor cell, what comes out from these tumor cells are all the intracellular ions, and the intracellular ions are like potassium, they are phosphate, and they also are uric acid, right? And therefore these all things increases. Because phosphate increases, there should be decrease of calcium also. So if you look at this question again, the question says you that for the management of tumor lysis syndrome, what would you give? So the options are alkalinization, IV fluids, raspberry case, and febuxostat. So what is your answer? देखो, for managing a case of tumor lysis syndrome, how you must proceed upon, first of all, you should know what are the findings going to occur. The first thing you should give is maintain a IV fluid. That's the first treatment of choice for any tumor lysis syndrome. Okay, that's a IV fluid, and along with that, you can give a normal saline also. Now, along with this, what you must also do is monitor the serum chemistry. Okay, you should monitor the serum chemistry. And then what you must start is after say 12, 24 to 48 hours, you must see the uric acid level. If uric acid is again higher, more than 8, you must also look at creat levels, and the creat level of 1.6 or more than 1.6, you must start the urate oxidase levels, and that is febuxostat. So the treatment should be given, then febuxostat can be given. It can be raspberry case can be initiated, and yes, probenecid can also be initiated. If nothing is working, ultimately at the last you must be doing hemodialysis. So these are the various treatment of choice, and Harrison very clearly tells you, even Robbins also tells you, that the alkalinization is no longer used in the treatment of the tumor lysis syndrome. So the answer to this question, very clearly, it should not be 1, it should be 2, 3, and 4. So your answer should be D clearly here. It should be D. Okay, that's the management of tumor lysis syndrome. This is a very frequently asked question, and what they often ask you is that whether they show hypercalcemia or hypocalcemia. And one more question I can tell you, one very frequently asked is, what is the first treatment of choice for tumor lysis syndrome? It is always IV fluid. Okay, and the last you must get hemodialysis, but the first treatment should always be the IV fluids. Okay. So this one, easy one, but I want all of you to just please participate here and tell me the answer. What is the answer do you think here is here? The BCR-labeled oncoprotein exhibits constitutive activity of which of the following enzymes? What is the answer here? Yes, it is surely tyrosine kinase. So, देखो tyrosine kinase is the inhibitor, is the drug that you give obviously. So, what happens is the BCR-ABL, if you remember, it's a translocation of 9 long arm, 22nd long arm, and this activates the tyrosine kinase, and this is what causes increase in the myeloid proliferation, and high myeloid proliferation will also lead to CML. One very frequently asked question you'll see here is what type of mutation you see here. It can be P190, P210, and P230. Remember, among in CML, this one is the most common. And do you remember, guys, I always talk about one thing, that if you don't get a question on CL or CML in a paper, or iron deficiency in a paper, something is wrong in the paper and there may be a re-exam. That is what confidence I have in these sort of questions. Yes, the answer here is surely tyrosine kinase here. Okay. Next question. Imatinib, dasatinib, nilotinib, and ponatinib. There are four types of tinib drugs, and they are second line drugs of, this is the first line obviously. This is the first line treatment. These are the second line treatment of the chronic myeloid leukemia. Are which classes of the drug? What is the answer, guys? Everyone, what is the answer here? Yes, Bhageshri, Dr. AC, Marela, Kessel, Bhavit, where are others? सब लोग आंसर करो मुझे. Where are others? Yes, the right answer is tyrosine kinase inhibitor. So as you get the treatment for this, you can just inhibit this one by giving tyrosine kinase inhibitor, and the example of the first and the second line TKI, and all of them start with a drug name called as tinibs. Okay, they all are tinibs here. The answer is surely D here. Very good. Okay, this one. Helicobacter pylori infection is associated with the development of which of the following lymphoid malignancies? देखो, answer here, guys. What is the answer here, first of all? Yes, the answer is mucosa associated lymphoid tissue tumor, that is called as maltoma. Correct. So the answer to this question is maltoma. Ab dekho, what happens in maltoma is, maltoma basically is a type of tumor which belong to the marginal zone lymphoma. I hope you remember from the classes, marginal zone lymphoma. And I would ask you always to answer this question when you have either a history of, yes, Sjogren syndrome, yes, or batao, Hashimoto, right? What else I told you? Yes, you should mark this only with a history of Helicobacter pylori infection or a chlamydia infection. Only with these possible obvious histology you should answer maltoma, else you should not mark this answer. About the other options, Burkitt lymphoma is seen in which infection, guys? Bolo? Yes, it should be seen in Epstein-Barr virus. Epstein-Barr virus infection also causes Hodgkin's lymphoma, and adult T-cell leukemia lymphoma is seen in HTLV1 infection, and it's a T-cell lymphoma. In this lymphoma, you often get a type of cell called as clover leaf pattern assay. You often get a clover leaf pattern. Burkitt lymphoma, you also know it shows a translocation of 8 with 14 or 2 with 8 or 8 with 22, and this often shows starry appearance along with the ALL-L3 type of morphology. Hodgkin lymphoma, as you all remember, it shows the Reed-Sternberg cell and is a classical and non-classical, the two types of Hodgkin's lymphoma. Anyway, the infection is Epstein-Barr virus for both Burkitt and the Hodgkin's lymphoma. Correct. Okay, now this one is a tricky one. First of all, you tell me what is your answer, guys. Everyone, what is your answer here? So, the functional pituitary adenoma arises from which of the following cells? First of all, remember, first functional pituitary adenoma. This I teach you all in my topic of MEN syndrome. Okay, in MEN 1, I talk about the most common type of MEN 1 in the pituitary gland is actually what? Prolactinoma. I hope you all remember this thing actually. Now, if you can answer prolactinoma, can tell me which do you think is the answer here? A, B, C, or D? Yes. So if you know the prolactinoma comes from which cells? Lacto. Obviously, prolactin है ना, तो lactotrophs. And therefore, the answer is B. Just remember, in men 1, you see this pituitary gland tumor. Just try to revise the men syndrome. Men 1, you see 3P, that is parathyroid. Remember, parathyroid, pituitary, and the pancreas, that's men 1. Men 2 AMA, I always talk about the mnemonic of happy. What is happy? H is Hirschsprung, A is amyloid, P is the parathyroid, next P is pheochromocytoma, and Y is the Melry thyroid carcinoma. Men 2B nowadays also as men 3, it has a mnemonic of 3M. This one is 3P, this 3M, Melry carcinoma thyroid, mucosal neuromas, and Marfanoid habitus is the mnemonic for men 2B or men 3. But obviously, if you talk about the pituitary gland tumor, the most common pituitary gland tumor is practinoma. The most common parathyroid gland tumor is the parathyroid adenoma more than hyperplasia, and the most common pancreatic tumor is insulinoma more than the gastrinoma. But remember, if you talk about the enteropancreatic tumor, then the most common site of that is duodenum and not the pancreas in that way. But however, the most common pituitary tumor in men 1 is insulinoma more than the gastrinoma. Okay, that is how you must revise the entire options. Okay, now this one, question 6. All of you, a tall, thin adolescent boy is found to have gynecomastia and small testes. His blood testosterone level is undetectable. Okay? Serum LH, FSH are elevated. The following is the likely karyotypic pattern. The answer is yes, it is 47XXY. It points towards a Klinefelter syndrome. Okay, it points towards a Klinefelter syndrome. देखो, how should we remember Klinefelter syndrome? Klinefelter syndrome is 47XXY. That means it's a male karyotype with an extra X chromosome. Because of one extra X, the testis fails to develop, and therefore these males often they have undeveloped testis, because of which the testosterone value is less. Because of low testosterone, the patient may be infertile or may also have delayed secondary sexual characteristics. They may also have a unique physique. They have a eunuch like body proportions with tall stature, tall stature with the long legs. And remember one very important finding: because of the low testosterone owing to the less development of testis, the LH FSH keeps on increasing. And also remember, if a male has low testosterone compared to estrogen, the estrogen testosterone ratio is a bit higher side and can lead to gynecomastia. This is a simple way how you must remember the finding of Klinefelter syndrome. Just remember is 47XXY. If I hope you all remember, the mnemonic of Turner syndrome is 45XO, and the simple mnemonic is clowns. Clowns में what is C? Cardiac anomalies. L क्या है? Lymphedema of hand and feet. O is ovaries are underdeveloped, called as streak ovaries. The W is the webbed neck. N is the normal intelligence, and nipples are widely spaced, called as shield-shaped chest. And S, last S, clowns में S है ना? That's a short stature with short fourth metacarpal, is a simple mnemonic for Turner syndrome. ठीक है? The following is a cause of relative erythrocytosis. I believe it's a very good question. First of all, you tell me what is your answer here. All of you. The following is a cause of relative erythrocytosis. देखो, the answer is relative. Therefore, the answer is diuretics, because this will lead to dehydration. Okay, dehydration. Had the question been not asking you about this cause of relative and would have been just erythrocytosis, I would have answered A, B, and C, all of them. Because the question asks you relative, it talks about a spurious cause. And the spurious cause can be seen in dehydration or can be seen also in severe burns. But therefore, the answer is D here, not A, B, and C. But if you don't look at the option of relative and you only look at the option of erythrocytosis, in that case, we'll mark simply A. But when you look at the other options, देखो, B can also cause and C can also cause. So it cannot be A, B, and C because वो तो option में नहीं है. Then you think, अरे, I have missed this word, relative, and come back to the answer, and the answer is D. That is diuretics is the right answer to this question, and not A, B, or C. I believe this is a very tricky question, and it might have fooled some of our students. Chalo, question number 8. Consider the following statements regarding inflammatory bowel disease. Ulcerative colitis involves terminal ileum and rarely cause proctitis. Dekho, ulcerative colitis, how do you remember this? Okay, first of all, you tell me the answer here. I'll then talk about this. All of you. देखो, ulcerative colitis, remember that U comes after C. So C is proximal and ulcerative is more distal. मतलब ulcerative is seen mainly in rectum and sigmoid colon. Okay, and the Crohn disease is seen mainly in the terminal ileum. So the first one, ulcerative colitis involves terminal ileum, that's a false statement straight away. Okay, Cowell stoning is in Crohn disease, that very is true statement, there's no doubt about it. Skip lesions are characteristic for ulcerative colitis. No, skip lesion is not seen in ulcerative colitis, is a finding of Crohn disease, and therefore this makes it false option. And ulcerative colitis more common in smoker. No, actually one very important statement, I talk about this in my classes also, that smoking often relieves pain in ulcerative colitis. This also becomes a false statement. So falling is correct, only second option looks correct, none of the other options look correct. The answer is D, very correctly D. I want more of you to just put your answers here. Yes, obviously Pradeep, Yogesh, Ganesh and Sai Bindu is also answering it. Wasim is also answering it. But I want more of you, just please interact with me, okay? Thickened ventricular wall with normal diastolic function is a feature of. देखो, because doctor the normal diastolic for it becomes what? It becomes a case of physiological hypertrophy of heart. And I hope you all remember the first page of my notes, first page of my general pathology notes. I talk about the physiological hypertrophy is seen in athletic bradycardia, whereas the pathological type of scene is seen in the hypertrophic cardiomyopathy, which can be seen in hypertension, it can be seen in other causes. But physiological hypertrophy will always maintain the normal diastolic function. It is athletic bradycardia seen obviously in the athletic heart. Okay, very good, perfectly answered. I can see more of you interacting right now, and please maintain this. Okay. Okay. This question 10. Fatafat. What is the answer? So in modified Duke's criteria, the following is not a major criteria. So I think we should discuss. First of all, tell me the answer here. Yes, the answer is simply Roth spots. Roth spot is not a major, it's a minor criteria. And now I will ask you, what is the major, what is minor? Let's understand this. Dekho. In the modified Dukes, the major is very simple. Remember, it's infective endocarditis. To prove I and prove E. How to prove I? It should be proven by infection. I is infection here. To prove infection, you should show a positive blood culture. Okay. Now, positive blood culture of infective endocarditis formed from two separate blood cultures. Okay. And it should be by typical organisms. So, typical organisms include the Hackett, it includes the Staphylococcus, Streptococcus. Okay. Or it can be a positive blood culture defined in the recovery of the microorganisms, and it should be blood culture which should be more than 12 hours apart, or all of the three, or a major of four separate blood cultures with first and second at least drawn 1 hour apart. One important thing you must also remember is even Coxiella burnetii. Okay, it can also be Coxiella burnetii. This is also taken as a single positive. इसका ना single positive is taken as a major criteria for this. That's very, very important. And second is the E matlab endocarditis. In the endocarditis, you have to look for the echocardiography, and it should be positive echocardiogram, or it can be an abscess, it can be a new dehiscence of the prostatic valve. Okay, it can be it can be echocardiography, in which it can be any type of anatomical deformity of the valve. It can be valvular deformity. Okay, it can be any type of partial dehiscence of the prostatic valve, or it can be a new valve regurgitation. So these are the two types of the major criteria. Okay, Now, in the minor criteria, just remember, it can be number one, fever. It can be any type of predisposing risk factors. Risk factors would include either a IV drug abusers. It can also be a IV skin catheter. It can be a dental procedure. All of those becomes a positive risk factor. Okay. It can be fever. Along with that, it can also be a vascular phenomenon, or it can be an immunological phenomenon. And the fifth one, it can be a blood culture, but in this time the blood culture positive is taken from a atypical organism, not a typical organisms. The atypical organism must be positive for the positivity here. Now, atypical organism is whatever we have not mentioned above. That becomes an atypical organism, like it can be Escherichia coli, it can be Klebsiella, it can be Pseudomonas. All of them come under the atypical organisms. So what Dukes talks about, it can be either two major, okay, it can be one major plus three minor, or it can be five minor. All of these are modified Duke's criteria. Okay, now there's something to be understood, what is vascular and what is immunological phenomenon. I have one more question for this that was also asked in this year's of CMS UPSC, so I'll come back to that again. Okay, next question. The following disease affects predominantly the large arteries. What is the thing answer? देखो, granulomatous with polyangiitis, what is this? It is called as vaginous granulomatosis. And vaginous is what? It's a small vessel vasculitis. Pan, you all know, is a medium vessel vasculitis. This is the answer. Large vessel, that is giant cell arteritis, also called as temporal arteritis. And eosinophilic granulomatosis polyangiitis, that is EGPA. It is actually Churg-Strauss syndrome. It's also a small vessel vasculitis. The right answer is very clearly C here. Okay, very clearly the answer is C here. Okay, चलो ये बताओ, Duffy antigen system serves as a receptor for which of the following parasite? So RBC में there's something called as Duffy, right? Duffy. And via Duffy, what enters? Okay, via Duffy, what enters? Bolo. 12. Yes, the answer is Plasmodium vivax. So Plasmodium vivax actually enters in the RBC for the Duffy, and therefore the Duffy negative RBCs, they are resistant. Okay, they are resistant to Plasmodium infection or vivax infection. They Duffy negative, they are resistant to the Plasmodium vivax infection. The right answer is B. Correctly answer is B. Chalo. With regard to transfusion therapy, cryoprecipitate is a rich source of which of the following? What is the answer here? Your answer, please. Yes, देखो. Two things will confuse you. One is the fresh frozen plasma. Remember, it have all coagulation factors are there, but they're slightly deficient with factor 5 and 8. Just remember this as extra information. Okay. Cryo precipitate often have factor 8 plus VWF plus fibrinogen. So because these are in the cryoprecipitate, the answer here clearly becomes yes, 1, 2, and 4. So 1, 2, and 4 is the right answer. The answer should be B here. Okay, answer should be B here. For those who are watching this video, let me tell you, this is a very, very important session. Similar type of question is often asked in INICET, especially the NEET PG. Obviously, is the clinical based question. You all know about it. But if you're preparing for INICET at all, the session is very, very important. Watch it live. And I'm not sure whether this will be recordedly available to you later on or not. To ensure you watch it completely, we will try to finish other questions also. Okay. The following can be transmitted via transfusion of a infected blood. What have you marked here? What is the answer here? Which do you think is a transfusion transmitted infection? TTI. which infection can be transmitted via the blood products. Because even though in the TTI we test for only 5 of the basic infections, but actually the TTI can involve multiple other infections also. Okay. Anyhow, what is the answer? Yes, in this case, it is all of these 4. 1, 2, 3, and 4. All of them can be transmitted by the transmitted infection. Remember one thing, there are 5 infection which you often test for. We often test for, testing is done for HBV, HIV, HCV, malaria, and syphilis. There are 5 things that we actually test for, even though the parvo B19 can also get transmitted, even HTLV1 can also get infected. But these are the 5 tests we often do, but the answer is surely all of them here. Okay, this is a simple one. The following describes the mode of entrance of hemophilia B. बताओ hemophilia B के लिए. Yes, it's very simple. It's extending recessive. I don't think we should discuss it any further. ये बताओ. The following condition characteristically may present with a triad of hemolysis, pancytopenia, and venous thrombosis. बताओ. 3 things. Is in which of them? Yes, the answer is correctly answered PNH. So PNH is a triad of intravascular hemolysis, pancytopenia, and the venous thrombosis. This venous thrombosis is not seen in every of the vessels. It is seen mostly in the hepatic veins and often can lead to Budd-Chiari syndromes. Okay, Budd-Chiari syndromes. About the other options, what is the triad of HUS? HUS is a triad of microangiopathic hemolytic anemia plus thrombocytopenia and along with that uremia. Hereditary spherocytosis, it is also a triad. Yes, the triad here is of jaundice, gallstones, and splenomegaly with spherocytosis. Okay. G6PD deficiency. This is often seen in a typical history of either intake of oxidative drugs or is seen in the infections or is seen with the ingestion of fava beans. The 3 conditions which can lead to G6PD deficiencies. Batao. The following is associated with the low MCV. Okay, so low MCV of RBC. Very simple question. Yes, the question answer is thalassemia. Thalassemia. 4 conditions can low MCV. One is thalassemia. One is iron deficiency anemia. One is sideroblastic anemia, and one is anemia of chronic disease. Remember that sickle cell anemia often shows normocytic normochromic RBCs. Obviously, it can show you sickle cell RBC also. Folate and B tables often show macrocytosis. Actually, here the right answer is A. Correct. The right answer is A here. This is a tricky one. Tell me. Answer. So in alpha antitrypsin deficiency, you all remember it is autosomal recessive. Okay. This is the wrong answer. Okay. Emphysema, you all know, can be seen. And alpha-1 antitrypsin is a very important cause of neonatal jaundice also. Okay. So now look at the options here. It cannot be D, right? So it cannot be D. तो ये तो चला ही गया ना? This is gone. क्या बचा आंसर? A. So even if you don't know it causes panicolitis or not, you should answer this question should cause panicolitis, but cannot be D. This is how you must simply solve the question. But panicolitis होता क्या है? So what happens is, because in alpha-1 antitrypsin deficiency, the patient has increase in protease enzyme. The high protease can also damage skin, and the skin damage can lead to what is called as paniculitis. The skin damage is what can lead to paniculitis. That is what you must know here. Okay, चलो ये बताओ. So vascular phenomenon and immunological phenomenon, I told you the two phenomena you should know. देखो, so in the infective endocarditis, there is something called as vascular phenomenon and there is something called as immunological phenomenon. In the vascular phenomenon, there is major arterial emboli, all of them which can lead to embolization. It can be infarction. Okay, it can also be mycotic aneurysms. Okay, it can be all types of hemorrhage, whatever is due to vascular events. Okay, and it can be a Janeway lesions. However, in the immunological, some books also call this vasculitic phenomenon. There's Osler's node. It can be Roth spots, okay, and can also be rheumatoid factor even. The point here is when we talk about a vascular phenomenon, it's all due to those which can lead to any cause of something due to a vessel getting involved. Okay, not due to inflammation. So Osler is what? It's an immunological phenomenon. Roth is a it also is an immunological phenomenon. Janeway is a vascular phenomenon, and even glomerulonephritis is actually a immunological phenomenon. So the answer to this question is C. The vascular phenomenon is a Janeway lesion. Remember, Janeway lesion कैसे याद रखना चाहिए? Janeway lesion में to walk through a way, I need my palm and soles, at least not the palm, actually the soles, and I can walk only if it is painless, right? So painless lesion in the soles is a Janeway lesion. It often happens due to the erythematous nodules or patches, I should say, not the nodules. It is because of the ischemic areas produced in the palms and sole of a patient who is suffering from infective endocarditis. So remember, the immunological phenomena are Osler's node, the Roth spots, rheumatoid factor, and I told you it's also is glomerulonephritis. So the answer here clearly is answer is C. Okay, vascular phenomenon is not Roth spots. Remember, Roth spot is a immunological phenomenon. Okay. देखो, question number 21, all of you. The most common non-pancreatic site, अभी बताया था ना मैं आपको मेन सिंड्रोम पढ़ाता हूँ ये आपको. Zollinger-Ellison syndrome is nothing but, yes, it is gastrinoma. Okay, nothing but gastrinoma. तो gastrinoma में क्या क्या होता है? Gastrinoma is a G cell tumor. Okay, it's a gastrin secreting G cell tumor, right? And occurs where? In the gastrinoma triangle, right? And if you talk about this gastrinoma, the most common site of gastrinoma is what? देखो, if the question is most common site of gastrinoma, it should be what? Duodenum. Okay, it should be most common location is duodenum. Okay, so the answer is here simply duodenum, not the stomach. The most common site of gastrinoma is not stomach. The most common site of gastrinoma is duodenum, not stomach. Dhyan rakhna. Okay, and yes, remember this gastrinoma triangle. Do understand the gastrinoma triangle. It is in the duodenum, second part of duodenum, and in the cystic artery and in the body of pancreas. That becomes a gastrinoma triangle. I again repeat, the cystic duct, then is the second part of duodenum, and in the pancreatic head and the body region, the midpoint of that is what makes a gastrinoma triangle. That's the most common location of gastrinomas. That's also called a Zollinger-Ellison syndrome. Often they present with the beta cell, non-beta cell tumor of the pancreas. Can basically the tumor is involved, and because of the gastrin secreting, there's increase in the gastrin. And I hope you remember the gastrin. Sorry, gastrin will stimulate what? Parietal cells, and the parietal cells will increase what? HCl production, and because of HCl there is ulcers. There's actually ulcers. There's a basic pathophysiology of this tumor. The following are the risk factors for acquisition of hepatitis C infection. बताओ C के लिए. The following is not बता दो. देखो, it is often blood-borne, yes, vertical and horizontal. So it cannot be fecal-oral. ये तो नहीं हो सकता. So the answer should be 2, 3, and 4. Simple है ना? Fecal-oral is not the basic mode of transmission. The serological detectable marker in the window period of Hep B. अब window period क्या होता है? So this also we make in our notes. I tell you, every of this question is right from your notes only, even in the class notes, not even the Gurukul notes. वो तो बड़ा vast है. Class notes से मैं आपको पढ़ाता हूँ ये सब कुछ. This how the we make a graph like this. I hope you all remember. So the mnemonic is SEC, reverse करो E और S. तो पहला है S एंटीजन, फिर अगला है E एंटीजन, फिर C एंटीबॉडी ऐसे आता है, ओके, एंड देन देयर इज द E एंटीबॉडी, and then after a gap of disappearance of the S antigen, there's appearance of the S antibody. Okay, तो ये क्या क्या है? It's a S antigen, right? इसको ऐसे लिख देते हैं HBsAg, ये वाला. This one is what? HBe antigen. Okay, this one is what? It's a IgM type of HBc antibody. This one is HBe antibody, and this one is HBs antibody. This period of the disappearance of the S antigen and the appearance of the S antibody, इसे कहते हैं विंडो पीरियड. तो विंडो पीरियड में क्या पॉजिटिव है? खुद ही देख लो, खुद ही बता रहा है. The answer is IgM HBc antibody is positive in the window period. तो इसका आंसर क्या होगा? Anti HBc IgM type. That's the right answer to the window period. Okay. अच्छा, this will also have to answer a lot of questions like what is window period, beta? Window period is an acute recovery, very recent recovery. The HBs antigen has just come to zero and the HBs antibody not even risen. That initial type of recovery from the infection is called as window period. Okay, so infection, what is the marker you get? These three markers. This is the infective phase, ये इन्फेक्टिव फेज है, और ये क्या है? रिकवरी फेज है. तो इन्फेक्टिव फेज में क्या क्या होगा? HBs एंटीजन, HBe एंटीजन एंड द IgM टाइप ऑफ HBc एंटीबॉडी. रिकवरी के ऊपर क्वेश्चन है. रिकवरी कैन बी रीसेंट रिकवरी. रीसेंट रिकवरी के लिए HBs एंटीजन शुड बी नेगेटिव. इफ इट इज IgM HBc एंटीबॉडी विद द HBe एंड द HBs एंटीबॉडी, इट्स अ रीसेंट रिकवरी. इफ इट इज IgG, okay, if it is IgG HBc antibody with a HBe antibody and the HBs antibody, it's a remote recovery or a old recovery. That is how you must remember the entire story here. 24. A 14-year-old boy came with chronic diarrhea and malnutrition. The physician suspected the celiac disease. The following is correct in his diagnostic workup. Batao. What is your answer here? देखो, presence of IgA endomycin antibody, yes, that's true. Absence of TDG antibody, that's false. Increased lymphocytes lamina propria, yes, that's true. अब option B is very tricky. क्या कहना चाह रहा है? Absence of reduced height of villi on the intestinal biopsy. Absence of reduced height of villi. Actually देखा जाए, then it's very tricky statement. Had the question been absence of villi, that would have been true option. अब question कर रहा है absence of reduced height of villi, that is a false option. But if you take this as, then होगा answer 1 and 2 is not possible. So 1 and 3, तो 1 and 3 होना चाहिए, but that's not possible, and therefore I am taking the option 2 also as correct. Answer is 1, 2 and 3. But actually speaking, the option 2 tells you absence of reduced height of villi. ऐसा नहीं होना चाहिए ना. देखो what happens in celiac. If this is the normal villi of the duodenum like this, right? ऐसे ये है क्या? Crypts, right? So what happens? The same diagram you also draw in your notes in the class, right? याद है? Complete loss of villi and the crypts become elongated and hypoplastic. And what you draw here? Huge number of lymphocytes. ऐसे करके. That's a celiac disease. So what you draw? Loss of villi. What you draw? Elongation of crypts. And what you draw here? Lymphocyte, which is B and T cells. B and T cells. And therefore, the answer should be not be actually 2, But looking at the options, we have to take the option 2 also as correct. The antibody you see is number 1, endomycel antibody, TTG antibody, and the gliadin antibody. The 3 antibodies and all of them are IgA antibodies. Question can also be asked among this, what is the most specific? So endomycel is the most specific antibody. TTG is the most sensitive antibody. Okay. And gliadin antibody often cross reacts with the skin antigen causing dermatitis herpetiformis. ये सबको जानना चाहिए. In celiac disease, including the HLA, yes, DQ2, DQ8, and B8, and often is caused with BROW, मतलब barley, rye, oat, and wheat can lead to celiac disease. इतना जानना चाहिए आप लोग को. Okay, चलो, जिसका आंसर क्या हो गया? A. Next question. This we discussed at chapter point 1. याद है? So, effective in uric acid nephropathy in receiving chemotherapy. What does it mean? It simply means same, tumor lysis syndrome. Okay, so acetazolamide, no, it cannot be used. Please understand. Alkalinization is not a nowadays used for tumor lysis syndrome. Probenecid, saline diuresis, and rasbericus, all of them can be used. So answer is clearly 1, 2, and 3. I have discussed this in detail in the first question in this entire discussion part. If you have not watched it, please go back and watch that part also. Okay. Okay, the PDF of this discussion will be available in my Telegram group. Please go there and you can download it after my session ends. Okay. Chalo. In serological investigation of Hep B virus infection, presence of Hep B antigen is an indicator of. बताओ क्या बताते हैं हम लोग? देखो, HBE antigen is what? It indicates replication, so infectivity, and so DNA load. So active replication virus in the liver is shown by the HBE antigen. The answer very clearly is A. Now this is a tricky one. इसका बताओ क्या लिखा आप लोगों ने? Think of the answer here, all of you. So simultaneous infection with Hep B and Hep D followed by full recovery is associated with appearance of. So what have you marked as an answer for here? देखो, what happens is, you all know this HDV is a dependent virus. And dependent virus on what? HBV. They can either be a super infection or it can be a co-infection. ठीक है. अब सुपर इन्फेक्शन में क्या होता है? That both HDV, sorry, in co-infection, HDV and HBV infects together. ठीक है. So what happens? You can get HDV RNA levels here, and along with that you get IgM type of HBC antibody in co-infection. However, if you get HDV RNA levels along with IgG type of HBC antibody, it's a super infection. ठीक है. अब देखो, the question is not asking you super infection, co-infection. Question is asking you that a simultaneous infection, मतलब कौन सा हुआ? Sorry, co-infection, right? And then there is a full recovery. Please समझो, simultaneous infection with full recovery क्या होना चाहिए? If it is full recovery, in that case you must get, पहले देखो simultaneous infection है तो IgM होना चाहिए, पहला तो क्लियर होना चाहिए. Along with that you get low levels of anti-HDV antibody of IgM type. ठीक है. That is the right answer to this question. Answer should be A. Answer must be A. Sir, when to mark it high titer? So in a chronic HDV infection, in a chronic HDV infection, often you get a anti-HDV in a high titer. Anti-HDV in a high titer, and it can be both IgG and IgM can be seen if it is a chronic HDV infection. And remember one thing, that because of the HDV replication, the HBV is not able to replicate, and therefore you often get a low HBV DNA levels. Low HDV DNA levels. That is how you must understand the entire topic here. The right answer to this question here is A. Low titer level of HDV IgM type. खुद सोचो how to spot it. Because it is simultaneous infection है, तो first of all it cannot be IgG. तो आपके दिमाग में ये तो आना नहीं चाहिए. You should also not think about IgA. It is not there at all. Yes, what can confuse you is it can either be high titer or can low titer. Remember, high titer is seen when the infection is still there, and low titer is there when there is full recovery. That's how you must understand the entire situation here. Okay, it's a tricky one. Therefore, I think you must all understand the answer. This can be again repeated in the upcoming INICET. It's a very good question and can also be asked in the upcoming INICET also. Please understand this. Okay, question 28. Batao, what is the answer here? देखो, RBC cause is seen in malignant hypertension. Yes, that's true. WBC cause malignant hepatitis. Yes. Pigmented cause in vasculitis. No. And glandular cause maglobinuria. No. So, which of them are correctly matched? Two of them are correctly matched. Answer is only two pairs are correctly matched. Let's answer some other things here. Like, sir, what do you expect to see in myoglobinuria? What you often see in myoglobinuria is often it shows a pigmented cast. Okay, it can show you a pigmented cast, and myoglobinuria can also show you some epithelial casts, and can also show you some epithelial casts. Okay, vasculitis can show you some RBC casts. This can show you some RBC casts. Vasculitis can show you RBC casts. Okay, and these two casts can be seen in myoglobinuria. So 1 and 2 are correctly matched, but I don't think the 3 and 4 you might have marked. So the answer very clearly is only 2 pairs are correctly matched here. Chalo. Next question. The following is primary underlying mechanism of PNH. बताओ क्या होगा? This is a simple question. All of you, come on. All of you should answer this. Yes, the answer is complement mediated destruction of CD59 RBCs. Very correctly. So what happens is because of the 59 negative and 55 negative and 59 negative, there is excessive complement activation, and that excessive complement activation causes a triad of symptoms of pancytopenia, intravascular hemolysis, and the thrombosis. Right answer is C. Okay, right answer is C here. The following is a clonal hematopoietic stem cell disorder in which phenotypically normal red cells, granulocytes, and platelets accumulate in the absence of recognizable physiological stimuli. कितना मतलब पूरा डेफिनेशन पूछ लिया तुम लोगों से, बताओ क्या है इसका आंसर? So since the question is accumulation of all these three cells, it talks about pancytosis. Pancytosis is never seen in essential thrombocythemia and in mastocytosis, right? Mast cell increasing is mastocytosis. Okay, now PCV may this increase of all these three, so it is the right answer. Now primary myelofibrosis can show you increase in pancytosis, but ultimately will show you what? Pancytopenia, and therefore the answer here is C. Had the option been CML, then I have taken that as the best answer. However, that not being in the options, you take in the answer as the polycythemia vera. The right answer is what? The answer is B. Answer is polycythemia vera. The answer is B here. ठीक है? Why not C? Because C shows pancytosis, but in the stage 2 and the main stage, fibrotic stage, it shows pancytopenia, not pancytosis then. Okay. So this is all the 30 question I could get in the first paper of the medicine and the allied subjects. I can tell you, if your base is very good, you can do so very good in the topics of medicine, pediatrics, and also the other subsequent topics as such as being asked here. Now I'm taking some question from the surgical based, and I can tell you again 15 questions were actually asked from this part of paper. The total I could tell you all of them from the notes only. You need not to see anywhere else also. The following statements regarding inflammatory bowel disease is correct. Batao. What is the answer here? Rectum is always involved in Crohn's disease. No. देखो Crohn's का main side क्या है? Terminal ileum. Even though Crohn's can involve any part of GIT, but always no, it's not always involved. First is false statement. ठीक है? The fistula formation is in ulcerative colitis. देखो fistula, perforation, stricture, fibrosis, all of them are seen in Crohn's disease. This also becomes false statement. Stricture formation is common in ulcerative colitis. No, again it's false statement. Again I repeat, because ulcerative colitis has superficial involvement, it will only show ulcers, large broad based ulcer, whereas Crohn's disease is the full thickness involvement, and hence it shows ulcer, fissure, fistula, perforation, stricture, everything is in Crohn's disease only. Perianal disease is common in the Crohn's disease. Batao. So, what is the answer here? The following is correct. So, rectum is always involved in Crohn's disease. No, that's not right answer. Always involved is always the wrong answer, obviously. Fistula and stricture is more commonly seen in Crohn's disease as an ulcerative colitis. So, perianal disease is common in Crohn's disease. Actually, this is also not a false statement. I'll say all four are false statement. Or false are false. It's very difficult to take out this option from this one. So all of them actually are a false statement. But if you look at the, I have to choose one of them. Since Crohn's disease involves any part of GIT, so I will say A is the best answer here. Elsewise, all these four are the incorrect statements. I can tell you once. Okay. The most common benign tumor of the liver is, yes, it is hemangioma. Remember, cavernous hemangioma. Cavernous hemangioma is the most common benign tumor of liver, even more common than adenoma. The adenoma ka most common is oral contraceptive pills is the most common etiology for adenoma, but it's not the most common tumor. FNH should be always differentiated from the focal nodular hyperplasia, should also be differentiated from nodular regenerative hyperplasia, and these two are very important because in focal nodular hyperplasia is only one node, and again this is again seen in oral contraceptive pills, whereas the nodular regenerative hyperplasia is seen in GVHD. It can be seen in many chemotoxic drugs and can also be seen as evidence of some autoimmune disease as well. So these two differentiations is very, very important. Angiomyolipoma is a tumor basically of the kidney and not of the liver. The following is a cause of exudative ascites. ये कहाँ पढ़ते हैं? We read this one in topic of cirrhosis, in the liver cirrhosis. To teach you this topic. Okay? देखो, congestive cardiac failure क्या होगा इसमें? Transurethral edema. Same for portal vein thrombosis. When you talk about any malignancy or you talk about any infection, often infection malignancy will lead to exudative ascites. And how to differentiate these two? You differentiate these two by SAG. SAG क्या होता है? It is serum albumin minus ascitic. Serum albumin minus ascitic fluid gradient. Okay? Ascitic fluid albumin gradient. So देखो how to remember this? If this amount is more, your SAG is less, and this amount is more in what? In exudative causes. Therefore, the SAG value, if it is less than 1.1 gram per DL or more than 1.1 gram per DL. Please understand again one thing. If this value is higher, your SAG value is lower. This value is higher in what? Exudative causes. The SAG is low in case of exudative ascites, and SAG is more than 1.1 in transudative cause of ascites. Now, I told you always exudative causes seen in any sort of infections, any sort of autoimmune diseases, and malignancies. They often show exudative causes, and transudative causes seen in portal hypertension. ठीक है, चलो. A typical case of iron deficiency anemia in pregnancy will show which of the following? बताओ. देखो, hemoglobin less than 10, yes, that's very true, correct. And therefore PCV less than 30, that's also is true, not false, sorry, true, true. MCC more than 30, no, that's false statement, it should be less than 30. And microscopic hyperchromic blood picture, yeah, that also is true. So the answer clearly is 1, 2, and 4. Simple question, 1, 2, and 4. Okay, बताओ this question. Okay, Schiller dual body is characteristic histological feature of which one of the following cancers? बताओ. Yes, the right answer is yolk sac tumor. And which of them is yolk sac tumor? Endodermal sinus tumor is a yolk sac tumor. Okay. This tumor में क्या मिलता है? In this you get lymphocytic infiltrates in the collagen fibers. Okay, collagen fibers. And along with that you get what? The typical seminoma cells or the dysgeminoma cells plus the tumor cells. Okay. Non-gestational ovarian carcinoma will show you what? The chorionic proliferation and will show you the beta HCG very, very high. Okay. Sex cord stromal tumor. इसमें क्या क्या आते हैं बताओ? Sex cord stromal tumor is of two types. Remember, one of them which can release estrogen and one of them which can release androgen. The estrogen releasing are what? Granulosa cell tumor and theca cell tumor. And androgen releasing are what? Sertoli cell tumor and the Leydig cell tumors. Okay, that's how you must remember this. And one which doesn't release anything is called as fibroma. That's called as fibroma. Simple enough. This answer क्या होगा? Anyhow, the answer is endodermal sinus tumor. And what they show this type of tumor cells. There are this type of two layer of germ cells, one layer and one more layer. Let me just draw one more layer here, essay. And actually these two layers of germ cells, they are inside, or I should say they are around a layer or area of vessels. ये vessel है, and around them you can see two layer of germ cells, and hence the name is Schiller dual bodies. Schiller dual bodies. Just remember a few bodies which can also be asked in this one. It can be a Brenner tumor, the epithelial Brenner tumors, and Brenner tumor shows what? It shows a Walther cell nests. Remember this. In the serous carcinoma of ovary, it shows you what? It shows Samoma bodies. Okay, it shows Samoma bodies. Schiller tuber, sorry. A papillary carcinoma often shows Samoma bodies. And one more, the Renke crystalloids are seen in Leydig cell tumors. Okay, Leydig cell tumors. Next question. The following blood values of iron deficiency anemia. Serum iron less than 30. Yes, that's true. Blood TIBC less than 400. No, TIBC should be higher. Okay, it should not be less than that. It should be higher than that. That's a false statement. Saturation less than 10%. That's true. And ferritin is below 30%. Yes, that's also true. So what of them is true? Answer is 1, 3, and 4. 1, 3, and 4. Please ignore this one here, this one, and this one. The answer is 1, 3, and 4. Remember this one very important finding. When you get a question on this one, you should know four things. Serum iron, okay? There should be serum ferritin. There should be percentage transferrin saturation and total iron binding capacity. ठीक है, अब क्वेश्चन देखो तीन चीजों के आएगा. आयरन डेफिशिएंसी अनीमिया, अनीमिया ऑफ, इसको बाद में रखते हैं, आयरन डेफिशिएंसी अनीमिया, ओके, sideroblastic anemia, and anemia of chronic disease. How to differentiate these two? The first thing you should all know is that the ferritin, please understand that ferritin level is inversely proportional to TIBC. That's the first thing you should all know. Okay. Now, dekho, if a patient has iron deficiency anemia, surely the serum iron should be low, right? Ferritin should be low. If iron is deficient, saturation should also be low. The moment you say low ferritin, the TIV should become high according to this ratio. This iron deficiency. And now remember one thing, the sideroblastic anemia is simply a case of iron overloading. Because it's iron overload, don't even think, just make this iron deficiency anemia opposite. Matlab, increased, increased, increased and decreased. What happens in ACD is the ferritin level is high. Because of high ferritin levels, TIBC is low. And why do we confuse ACD with IDA? Because iron and saturation both are low, and hence we confuse these two. So I would ask all of you to look at this value and look at this value. They always go opposite. It'll really make your table very, very easy. Simple table hai ye. Chalo. Ratio of type 1 to type 3 collagen in the maturation phase of remodeling phase. बताओ, देखो, normally if I ask you in normal skin, which collagen is more? 1 more than 3. In the initial part of wound healing, what happens? Type 3 gets deposited. And I hope you all remember, I tell you always, after 1 month, there is remodification of collagen. Remodification ka matlab, all the type 3 collagen is replaced by type 1 collagen. And therefore, remodification may 1 is more than 3. And how much? 4:1. 4:1. ठीक. चलो, this is a bit tricky question, but see if you can solve it. देखो, the nickel and chromium, they don't cause skin cancer. Remember, these two both cause lung cancers. Okay? Bladder is seen in occupational dye stuff. Which dye? I teach this in the topic of bladder carcinoma. It's benzidine dye. And wahin par, I always mention, he always has confusion is with benzol or benzene. The same as benzene or benzol, same hai. And this causes acute leukemia. So 2 and 3 are true statements. Lung cancer is in electric cable industries. देखो, electric cable industry, that often is a byproduct of electrical, and that is arsenic. And actually, the arsenic, if we talk about the lung cancer, to solve this question, suppose you don't know about the 1 and 4, but if you know the 2 and 3 are correct, अब देखो 2 and 3 यहाँ पर है, there's no other possible answers, so you have to take this only. Now, about the electric cable industry can cause often, it all depends on what is being used there, honestly. But let's make a small list and see if it is helpful for you. So, arsenic, I'll talk about the carcinogens, and the cancer they can lead to. Okay, if you want to, just please make a list of this. So, first I'm writing arsenic, okay? Arsenic. It often leads to lung cancer and also lead to skin cancer. Okay? Then there is asbestos. Asbestos often lead to lung, esophagus, gastric, and the colon carcinoma, obviously with mesothelioma. You obviously can't forget this one. Okay. Then there is benzene, and benzene causes acute leukemia. Okay, acute leukemia. Then there is beryllium, Beryllium can often lead to lung cancer. Yes, dye contains benzene. I'll talk about this. Okay. Cadmium. Cadmium. Cadmium often leads to the prostate carcinoma. Cadmium often leads to prostate carcinoma. Chromium. Chromium. Lung cancer. Okay, lung cancer. Nickel. It leads to lung carcinoma and the esophageal carcinomas. Okay. Radon often leads to lung carcinoma. And vinyl chloride often leads to liver carcinoma में angiosarcoma of liver. Angiosarcoma of liver. Angiosarcoma of liver. So just try to remember this if you can. That's an important point here. So most of them are lung cancer. देख रहे हो, lung cancer is here also is lung cancer, lung cancer, lung cancer, lung cancer, lung cancer. तो अगर समझ में नहीं भी आए तो at least you must mark lung cancer. Most of them are causing lung cancer only. That's what you must approach the question. But देखो benzene ये बहुत पूछा हुआ है. This question is very frequently asked, and vinyl chloride is very frequently asked. These two are very frequently asked. I can tell you one thing. Okay. चलो, ये आ गया Zollinger-Ellison syndrome again. तो yes, it causes permanent gastric ulcer. बढ़ा चुका मैं आपको. Alsatian defined treatment, yes. Non-basal tumor of pancreas, therefore it causes gastrinoma. And recurrent episode of dysentery, not. It causes recurrent episodes of diarrhea. तो क्या होगा आंसर? 1, 2 and 3. That's a simple one. I'll not discuss it again. The following are correct with regard to FAP. बताओ. What have you marked for this? देखो. So APC is on short arm of chromosome 5. Actually, APC is on 5q, not 5p. ठीक है? It is autosomal recessive? No, it's autosomal dominant. ठीक. It is 100% lifestyle risk. Yes, that's very true. And congenital hypertrophy or retinal pigmentation is present in half of the cases. That's also is very true. In fact, this is the extra intestinal manifestation of the FAP syndrome. So actually, the answer must be 2 and 4. But a problem क्या है कि इसमें 2 and 4 कहीं पर है ही नहीं. And therefore, maybe I don't know how they have missed it out or what may might have done is, देखो इसका answer, the only possible answer is A. Even though it is not 5P, it's 5Q. But I don't know how they have made that question. It looks to be a wrong answer. And if there's any way you can just point it out to the CMS, I've already mailed to them. I have done my job. It is because if you've written the exam, you must also email it to them. And therefore, you must also do this. According to me, the answer cannot be anything. But just to make it an answer, I'll just mark 1 here. Okay. Chalo. But the following has 2 phases of the first simple pneumoconiosis and second is progressive massive fibrosis. Remember, PF is seen in all the 3 pneumoconiosis, but it's more severe in, yes, Cole-Worker pneumoconiosis. What is Cole-Worker? That's anthracosis. Cole-Worker is anthracosis. Okay. So that is all about this today's discussion. I'll just share this all PDF with you all in my Telegram group. I hope you are the member there. And please understand one point. This entire discussion makes you understand that how important a subject like pathology is. In this year's CMS exam, it is full of pathology. Microbiology was also major chunk in paper number 2. Okay, if you look at this paper number 2, was major chunk was microbiology. So please make your second year topics very strong. नीट होगा, नेक्स्ट होगा, INICET होगा, क्या होगा, फलना होगा, ढकना होगा, कुछ भी होगा, subjects will not change and the base will never be weak. Please study and make yourself very strong in your basics. It will always help you solve a clinical question in a better format. Okay, it's very nice. I'll not discuss this very in a long manner right now. If you like the session, Please put a like to this video if you really liked my approach of discussing this question short and sweet. Please put a like on this, and please share to your friends also. The PDF of the session I'm just going to upload in my Telegram group. You can download it from there. I can also practice the question as and when the INICET comes forward. So guys, see you all. Thanks for your valuable time. Okay. So guys, thanks a lot for giving your valuable time. We'll discuss again some other questions as exams come forward. And yes, if you have any other queries, you can put in the comment box below. I'll again take it up for the next time. If questions from my yes, Vijit, I'm very sure. If the question is from your notes, do not make it wrong. The only thing I can tell you, every faculty tells you, इतना question मेरे notes से आया, इतने question मेरे notes से आया, कैसे वो कहते हैं? What confidence we have? It's not that we teach you what they ask you. No, we teach you common stuffs, and common stuffs are asked. Remember the basic rule. You'll always do better and best. Take care. God bless you all. Goodbye. Can any of you please share my Telegram group link? Maybe they can join it up here. Chalo, take care. Goodbye. Bye bye.